When we think about a clinical incident in healthcare, our focus is placed on the patient or consumer that has been harmed. We often see these people as victims of substandard care or avoidable errors that have resulted in harm. But by focusing solely on our patients, we sometimes can forget that there are other people involved in a clinical incident that may also be victims. Victims of poorly designed or inadequate resource systems. Victims of a range of human factors issues such as fatigue or distraction, and victims of normal and expected forms of human error. The second victim is a term we use in healthcare and across other industries to describe the fact that it's not only patients or consumers that are harmed by clinical incidents. Those who are involved, and in some circumstances even responsible for a clinical incident, are also victims, and we need to understand and respect and support them as we do our patients. The term second victim was introduced by Albert Wu in an editorial published in the British Medical Journal in the year 2000. Now, some 20 years later, we are still on a journey to adequately acknowledge and respect the second victims involved in clinical incidents. There is an excellent book on the topic written by Professor Sidney Dekker that is well worth hunting down. However, for the purposes of this short video, it's worth highlighting a few key concepts. The first important point to consider is how we support our colleagues who have been involved in a clinical incident or those who have inadvertently caused harm in the way in which they've delivered care. A clinical incident can be a very traumatic event and create a range of adverse psychological outcomes. It is important to note that if not effectively managed, significant long-term harm can occur as a result of a clinical incident. Activities like post-incident debriefs, critical incident stress management, and psychological first aid are critical in minimising the long-term damage inflicted on doctors, nurses, and other clinical and non-clinical staff after an incident. When a clinical incident occurs, we need to think both of how we minimise harm to our patients, but also how we minimise harm to our colleagues who were involved. The way in which we conduct clinical incident investigation also needs to respect the fact that there are nearly always second victims to consider. Second victims often feel like they are the focus of the investigation, both professionally and personally. Rather than a clinical incident being the focus of investigation, we often create the sense that it is the individuals involved who are being investigated. This is not helped when we constantly see in the media headlines relating to the actions taken to punish clinical staff involved in a clinical incident, and the fact we have not yet properly decoupled the investigation of clinical incidents from processes relating to performance management and blame. A good investigation should never be satisfied with identifying that someone did something wrong. Rather, a good investigation is defined as one that understands, from the perspective of those involved and with respect, why actions were taken that may have inadvertently given rise to a clinical incident. To this end, making sure the individuals who are involved in the incident are able to contribute to the investigation through discussing the event with the investigation team is important. Indeed, it's the individuals involved who often have the greatest insight into recommendations for system improvements. To this end, the focus of an investigation of a clinical incident should be our broader systems and practices involved in the delivery of care. In this context, those who are second victims provide valuable insights into the gaps, vulnerabilities, pressures, and cultural norms that are the real causes of a clinical incident. One of the most important things to do when conducting clinical incident investigation is to avoid hindsight. It's very easy, after the event, in the cold hard light of day, to say, this incident would not have occurred if only someone had done something differently. This hindsight bias is symptomatic of the person approach to clinical incident investigation that satisfies itself with burdening individuals with responsibility and blame. An alternative and much better approach is to take insight from those involved in a clinical incident, respect that we are all working in an imperfect system, and take their unfortunate experiences as learning opportunities to improve elements of how we deliver care. Clinical incident investigation is not only about finding out what occurred. It's also about understanding why a clinical incident happened, both through listening to the lived experience of those involved and also respecting those that involved are often second victims. It is our duty of care to look after those involved in a clinical incident, provide support where needed, and ensure that the outcomes of the investigation lead to systemic changes to make our facilities safer for both our patients and for our colleagues.